Good afternoon. I have the inauspicious honor of giving the last talk of the last session of the last day of this wonderful meeting. And the sun is out in the warm city of San Antonio, so I thank the audience for their time and attention. Today I'm going to talk about abdominal pain in the adolescent female. As far as I'm concerned, being the mother of a 12-year-old, I hear that this is a especially difficult subspecies of the population. I haven't experienced it personally, but I hear that this is a problem. Our session will start with a few definitions that pediatricians, gastroenterologists, gynecologists, surgeons, and pain specialists share regarding abdominal pain. SAGES is an organization that brings several subspecialties to the table when dealing with difficult topics, so I think this is a good thing to go over. We will also highlight the differences among children, adolescents, and adults, and then we will take a couple of case scenarios to go through the workup and the differential diagnosis, noting diagnoses that are seen primarily in the adolescent period. Oh, I have no financial disclosures. So in terms of defining abdominal pain, organic pain is pain that originates from a specific disease process where treatment of the disease ameliorates pain. So appendicitis, PID, ovarian torsion. Dysfunctional pain are pain sensations that originate from normal rather than disordered physiologic processes. There's two types. Specific dysfunctional pain comes about from recognizable pain mechanisms. So for instance, Mittelschmerz, dysmenorrhea, lactose intolerance, pregnancy. These are normal processes, and there's pain sensations that originate from these processes. Non-specific are the more challenging types of pain where there is no apparent recognizable pain mechanism. Sometimes they spontaneously resolve early or late, and sometimes they can be persistent. And these are the adolescents that we see in our clinic. Psychogenic pain, in contradistinction, is experienced in the absence of these disordered patterns that originate from the intra-abdominal area. So these are psychologic in origin, and there's often a relationship between the pain that is experienced and relevant psychologic events. There is often a positive evidence for relevant disordered intra or interpersonal behavior patterns. So our first case, you guys have never seen this before, is a 15-year-old female that was referred to your clinic with intermittent periumbilical pain for several months now. She's been out of school several times, and she reports no urologic or gynecologic symptoms and no changes in the daily stooling pattern. So this is a typical slide that we give medical students, residents, and us. And this is just to remind us the usual hierarchy of how we work up these patients. So let's just go through some general principles touching on what Dr. Purcell Jackson had alluded to earlier in this session. Acute presentation of abdominal pain is likely to have an organic, surgical, or medical cause. So in dealing with acute pain in this population, the entities that may have potential severe consequences, such as appendicitis, ovarian torsion, PID, pregnancy, should be included. But these etiologies are the gimmies, so usually these are the things that we know what to do with, so we won't go through these in detail. Now, adolescent females with recurrent or chronic abdominal pain present a more challenging diagnosis. Recurrent pain is more associated with dysfunctional entities. Often, the diagnosis involves not just defining the syndrome. Especially in adolescent, it is important to elicit secondary anxiety and dysfunction that stems from the symptoms. A staged and careful evaluation is the key to helping this patient, so not a shotgun approach. The treatment can be specific to the problem, but oftentimes may also include treatment for the symptoms stemming from the process. An important tenet to remember is that localization and differentiation between pressure and pain are skills that are already developed by the time they're adolescent. The Apley principle says the further the pain is from the umbilicus increases the likelihood of an organic cause. We also use this in dealing with kids. And then lastly, remember that stress should never be a primary and absolute etiology for pain without a workup. I just operated on a young man who everyone thought was stressed because he changed schools. Turns out he had mediastinal histiocytosis. In eliciting the history and evaluating adolescents, several principles are key. So conditions present differently in adolescents compared to children and adults. Their coping mechanisms, their communication skills are different at this particular stage. Conditions presenting at all ages become more prevalent during this time as well. And then conditions relating to the GYN system enter in the differential diagnosis. When interviewing them, you must take into account that there are lifestyle changes and environmental exposure that may be different from what their parents have. This is the time when they are trying to gain independence from their parents. The evaluation of symptoms should also include anxiety and dysfunction that may result from the symptoms. And beware of missing information due to shyness concerning sexual function. They may also deny significance of certain symptoms that they have. This slide is just to remind us that it's not just the GI system that we should consider in this particular age group, but also should include respiratory, endocrine, gynecologic, infectious, psychologic, and social systems. Additionally, the physical examination should be careful and detailed. Just like in pediatric patients, performing the perianal and gynecologic exam should be done in a thoughtful manner. So for instance, if I have a patient who is not sexually active and may need endoscopy under anesthesia anyway as part of the workup, I would consider combining the procedures of an examination under anesthesia with one of my GI colleagues as he is doing the endoscopy, and really using gentle instrumentation. I typically use a nasal speculum to do the GYN exam. Basic laboratory tests, they usually come with these anyway, but may include hematologic and inflammatory markers. Pregnancy tests should be done as well, and if the child is sexually active, cultures for sexually transmitted diseases. According to my gastroenterology colleagues, there are more specialized tests, but again, a shotgun approach is not the thing that we'd like to do. Ordering this test should be done thoughtfully and specifically. So stool may be tested for infectious etiologies depending on their travel and their dietary habits. Alpha-1 antitrypsin can be sent in the stool for protein-losing enteropathy. Calprotectin is a good serologic marker for IBD now, and a breath test for lactose and fructose is helpful for bacterial overgrowth. And again, there are serologic tests for amoeba and H. pylori that may be considered as well. Now, imaging studies should be selected sparingly, correlating the signs and symptoms with the signs and symptoms that you elicit. So ultrasonography is better for pelvic imaging and the biliary tree. MR enterography is something that our pediatric gastroenterologists like nowadays to take a look at changes associated with inflammatory bowel disease. So Meckel's disease often present as painless hematochezia, but may also present as diverticulitis. So there have been a couple of instances when one thinks one has a slam dunk appendicitis, but it turns out to be a Meckel's diverticulum, so that would be something that you shouldn't miss. But in this particular age group, as they're growing, one should always think about decreasing the radiation exposure when you're working these patients up. So if you don't need to do the CT scan, and there's something else that you could do, then that would be something to consider. And also talk to your radiologist about decreasing the amount of radiation that they can have. Endoscopy is a tool that is used to help diagnose abdominal pain. In an adolescent female with recurrent and/or persistent pain, endoscopic evaluation is often performed before laparoscopy, but should be definitely done when there is evidence of bleeding from the GI tract. Colonoscopy should definitely be considered in patients with diarrhea, disordered stool patterns, and abdominal pain with no infectious cause. Here are some endoscopic pictures of some entities seen in adolescents. Eosinophilic esophagitis is a kind of the sine qua non of a child or adolescent with some epigastric pain who suddenly, chokes on a steak. Has that kind of cobblestoning pattern that you see in the right upper quadrant. Eosinophilic, the classic presentation, Crohn's disease is seen with some inflammatory changes. Ulcerative colitis is also something that can be seen on endoscopy. And these antral bumps that you see in the right lower quadrant is something that you see with H. pylori enteritis. All right, so when should diagnostic laparoscopy be done? Because these are the, when these children present to your office. There is literature that supports the use of diagnostic laparoscopy in the unexplained acute abdominal pain in less than 7 days duration if the initial workup yields no diagnosis. It also may be a reasonable alternative to close observation for patient with non-specific and recurrent abdominal pain. In fact, this is probably the current practice in the management of these rather challenging patients. SAGES actually has recommendations on when to use this in adults. There is grade B evidence that laparoscopy is feasible and safe in patients with acute nonspecific abdominal pain. Laparoscopy may be considered in patients without a clinical diagnosis for recurrent abdominal pain, but our website and our organization says that non-invasive options should be considered first. And there is some evidence that it may be better than observation in that particular population. When doing laparoscopy, you should rule out the presence of hernias, Meckel's diverticulum, inflammatory bowel disease, or evidence of inflammatory process such as adhesions. So you're there, you don't really find anything, so are you supposed to just take their appendix out? There is level 3 grade A evidence that suggests the utility of performing a laparoscopic appendectomy if no pathology is defined during laparoscopy. This may be a little bit more defensible in adolescents who are looking at their whole lifetimes to develop appendicitis. And there is level 2 grade B evidence that in patients with slow gallbladder emptying that has been documented preoperatively, that they may benefit from laparoscopic cholecystectomy. You should be careful to tell the parents that you may not treat their abdominal pain. And in fact, I tell them that the laparoscopy, more often than not, is part of the diagnostic armamentarium just to make sure that there's not anything else we're missing with our history exam tests and imaging. What about pelvic laparoscopy? Firm recommendations have not been made. There's some grade B evidence that says we should take a look at the pelvic organs. I do all the time. I look for evidence of endometriosis. If there's some adhesions that are there, I may try to divide them depending on how significant they are. Now, there's some literature that suggests that random biopsies may demonstrate endometriosis in up to 30% of patients with typical symptoms. Some gynecologists and some pain doctors actually have looked at conscious pain mapping. For, if I had to do any significant work in the GYN area, I actually have one of my adolescent gynecology colleagues help me out. Endometriosis is not one of those things that just kind of jumps out at you. It's, sometimes it's white, sometimes it's kind of brown and all that stuff. And I think in this particular population, I actually invite them if I am worried that there might be some gynecologic entities, because then they will be able to follow these young women for a longer time. So let's go through a couple of diagnoses that we as surgeons kind of cringe when we hear about them, but certainly some diagnoses that we see in this population. Now, irritable bowel syndrome occurs right around late adolescence. The pain is typically dull and crampy in the left lower quadrant or the periumbilical area. The intestinal dysmotility is often manifested by nuisance diarrhea or constipation. So it's not one of those things that keeps you out of school typically. And there's some autonomic features that may be common. Stress definitely can induce flares up, and dietary modification, fiber, Activia have been used to help with this. Now, recurrent abdominal pain syndrome is a diagnosis that is seen in childhood, but also in early adolescence. The pain is vague and is unrelated to meals, activity, or stooling. There may be a family history of irritable bowel syndrome. Diagnostic tests and imaging really yield nothing positive, and the treatment, according to my GI colleagues, is just emphasizing the normality of the schedule, but may also require a psychologic evaluation. Cyclic vomiting and abdominal migraines are also seen in this age group. Cyclic vomiting is characterized with 2 or more periods of intense nausea, vomiting, and retching that last hours or days. These are debilitating for these adolescents. Then these patients return to their usual state of health, which lasts weeks to months, and then it can happen again. In fact, these can be so severe that often during the times when they have these problems, they need to be hospitalized, get IV fluids, because they can get pretty dehydrated. In contradistinction, abdominal migraines, they have symptoms that are associated with intense abdominal pain. With cyclic vomiting, it's usually just the vomiting. Although antiemetics have been used, it is like migraines. You identify some triggers and you try to avoid them, and I think that's usually the mainstay of the treatment. So our second case is a 14-year-old who was diagnosed with year-long constipation by her pediatrician. She was actually getting a physical exam to join her volleyball team when her family doctor thought she had an abdominal mass. Her ultrasound showed a large cystic mass with no visualization of the right ovary. So before she comes to the clinic, a CT scan was ordered, and this is what it showed. When I asked her mom about this, she goes, "I was kind of hoping she wasn't pregnant." Physiologic or functional cysts, such as follicular or corpus luteum cysts, consists of majority of masses in the adolescent female. So controversy exists as to when surgical intervention is indicated. But in general, it should be considered definitely if the cyst is greater than 5 millimeters. In the pediatric literature, we actually say about 5 to 6 because we worry about ovarian torsion. Definitely if it's enlarging over time, has some solid components, or symptomatic. Our gynecology colleagues also say that if it persists for more than 3 to 4 months at that particular size, probably we should do something about that. Polycystic ovary syndrome does not warrant surgical intervention. Now, dermoid cysts or mature cystic teratoma, which was that greater than 20 centimeter cyst that I showed you in the previous slide can definitely lead to ovarian torsion. So those you need to remove, if not only to prevent ovarian torsion, but also for diagnostic accuracy. Now, for this particular case, cystectomy is the treatment. Endometriomas are not typically seen in adolescents, but do not regress with hormonal therapy and need to be addressed. Now, epithelial ovarian tumors, such as serous or mucinous adenomas, are infrequently seen, but they can get very large and has the possibility of low malignant potential, so they need to be removed as well. Ovarian torsion is treated by detorsion with an 87 to 95% ovarian salvage rate. This is the one thing that I wanted you guys, one of the things I wanted you to take away from this talk, is it used to be that if you see a very black ovary, you just remove it. Actually, the standard of care now is that you detorse the ovary and you kind of leave it alone. And there's been really good evidence that says there's no evidence of PEs. And if you look at that ovary several months later, oftentimes it's been saved. And there's not a lot of pain associated with it as well. Malignant ovarian pathology is rare in this age group, but not impossible. In my, I think, 8 years in Milwaukee, we've had about 3 Sertoli-Leydig tumors. The goals of surgery are different. It includes confirming the diagnosis, staging the tumor, removing the tumor, and in this particular age group, preserving fertility. To optimize these goals, we actually have adopted doing a combined pediatric surgery gynecologic oncology approach to these tumors. There are several biologic markers. Often for germ cell tumors, we always send the AFP and the beta HCG, but inhibin levels is one of those things that you have to send for Sertoli-Leydig. Okay.
Thank you, Marjorie. We're a few minutes over, but I'm blaming Butch Rosser for that, so we'll entertain a question or two.
Joe Dodd, Nevada, Missouri. In adults, and a lot of the adults we see with chronic abdominal pain, functional pain, we often end up putting them on trazodone or Zoloft or those agents. Where I'm located presently, I do take care of adolescents and see them with, then I get shunted the functional abdominal pain. And there's these huge black box warnings, you know, with the use of antidepressants in adolescents and the like. Are you, I've actually started them, but told the patient or mother to be very careful, and if there were any issues, you know, call me right away. What are we supposed to do?
What we've done, this is even one of those more cringing diagnoses that we sometimes give these kids, is this visceral hyperallergesia syndrome kids. You know, it's kind of just like, oh, that hurts. But we have used it in children. We start with a very low dose and we get an EKG first to make sure that their QT interval is normal. And then start with that and see how it goes. It's not a long-term thing as in adults as well, but we usually get one of our pain medicine doctors to help us out when we're kind of at that end of the rope.
I'm going to put a plug in for something that seems a little odd. Those of you who know me know I have other interests, and I actually have boards in hypnotherapy. And there's really good data in that literature, and if you look at it, it's very clear that this is one area where hypnotherapy can be very effective, particularly in adolescents. And I've gotten a lot of very frustrated parents and physicians sending me patients over the years. It's oftentimes one session. That's the typical. Sometimes it's an additional follow-up, but if you have frustrated kids, I'd far more frequently consider that as an option if you have someone talented in your area to refer the patient there rather than put them on drugs that potentially have harmful effects.
Thank you.
Thank you all for staying for this late afternoon session. We're happy to offer you 5 extra minutes of SAGES and hope you have safe travels home.